Good evening. It's evening already. And as I'm last speaker of today, Mwenyekiti, please allow me to greet you. Jamhuri ya Muungano wa Tanzania. Jamhuri ya Muungano wa Tanzania. Yes, this is a famous slogan of our President, Her Excellency Samia Suluhu Hassan. So I'm proud to use it. So I also got a challenge when I was told to prepare something to do with choosing wisely in pathology, especially in our Tanzania context, and as the diagnosis of cancer is concerned. As I looked around and I said, like in pathology, like everything we do is important. Everything we are supposed to do in pathology is important, but who are telling us to do is the clinicians. You are the ones who are deciding of what are we supposed to do. So we know like many deaths can be prevented if we have appropriate and timely diagnosis and management of cancer. And you can find pathology services are in place because without identification of a disease, histological type, the stage, you cannot treat that patient. So it's very important to have pathology services in place and fully functioning. So as in cancer control from screening, early diagnosis, treatment, and follow-up, we see pathology has a huge role in all these stages. And when you talk of laboratory medicine and pathology, these things are inseparable. Like in other settings, when you just say pathology, you mean everything that is done in the lab. But in our setting, and as cancer diagnosis is concerned, when you talk of pathology, most of the time you mean as histopathology and cytopathology. And your main role is to examine the morphological changes of the tissue, that is histopathology, and the cells, and that is cytopathology. But then things like clinical chemistry, like immunopathology, forensic pathology, biochemistry, and all those things that are done, they are part of laboratory medicine, and pathology is among them. So why do we need to choose wisely in pathology? You might find like in low and middle income countries, even when the pathology services are existing, they are often under-resourced in terms of trained personnel and the equipment. You might find the equipments are there, but then the supplies are not available. Or sometimes you may find even the equipments are not available. And all these together, they lead to have unreliable quality and delay in diagnosis of cancer. So this is just a graph which was done by WHO, and they looked around to see the percentage of countries reporting pathology services. So when you look at there's this part here, it shows the WHO regions, and the countries were grouped like in economic status. And you may find Africa is lagging behind. Whether you name the region itself or you name it by economic status, we are all lagging behind, and Europe being there at the top. So with all this, coming back to Tanzania, you don't even need funds to do your research. You can just sit in your office and number the pathology services that are available in the country. You can just take a piece of paper and just name. Find Mwimbili, KCMC, I don't know. Never mind the private settings. You can even name the pathologists. You can even name the machines and the brands and the investigation and the supplies. So it's all cumbersome. So when you need to choose wisely in pathology, there are two groups of people who are interested in all this. We have the clinicians, we also have the pathologists, and all people who are working in the lab. So the clinician is interested in the report, the last report, what it has. But then the pathologist and people who are working in the lab, the histo lab, are interested in specimens. The specimens are our priorities. The specimens, the request form, those are our priorities. Those are our patients. And those are the things that we are talking with them every day. We don't have like real patients, we have the specimen. So whatever goes in the lab, you have to know at the back of your mind, the report will be like a reflection of what has been brought into the lab. So like any other investigations that you send in the lab, in histopathology also it passes through different phases. We have the pre-analytical, we have analytical, and post-analytical phase. And all these, they reflect the movement of specimen in the lab. Although the pre-analytical part, most of it is done by the clinical services, is the role of the pathology department to make sure it has proper and all the things that are done in pre-analytical that are good and are stated in the good quality so that we have a proper report at the end. So from there, from the pre-analytical, we have things like from the collection of specimen identification, we have like filling the request form and those things, and even the transport. So what are the things that are important so that we have a good report at the end? So from the collection of specimen, first of all, whoever who is responsible for the collection of specimen should understand the clinical history of a disease, the natural history of a disease. So before you are taking a specimen, at the back of your mind, you're supposed to understand, what am I dealing with? If you don't know, if you don't have the appropriate sampling method techniques, then don't do it. Because when you do it, you just cause harm to your patient. And then the last report won't have everything that you want. Also, you have to know that inappropriate sampling can result in poor specimen collection and negative influence the final diagnosis, as I've said. So there are different types of specimens that we have. From the surgical part, specimen and cytology. As I said in the beginning, that in pathology and cancer diagnosis is concerned, these are the two things that I'll be dealing with. Leave alone the molecular part or the immuno part at this point. So from the surgical specimen, we have things like core needle biopsies. And this, we find them like an example of the sites. We have the breast and the bone marrow. We also have the endoscopic bios from the nose, sinus, gastrointestinal tract, the bronchus and the lungs. And also we have minimally invasive surgical biopsies. For example, the incisional biopsies, the punch biopsies, for example, from the thoracic, abdominal, and pelvic organs. And also have surgical dissections, like any organ, like you might find somebody is doing mastectomy and such things. And from the cytology specimen, there are things like smear, body fluids, and aspirates. And in smear, you can have like a site like specimen, the vagina. Those are the places which you can get your smears very well. But then the body fluids, they're supposed to take them as they are, put them in a proper container, and then send them to the lab. The aspirates can be done in two ways. You can send a person to the lab so that the aspirates can be done in the lab, or in other settings, the aspiration is done at the clinics, and then only the samples or the slides are taken to the labs. So whatever you're doing, for example, you're doing your aspiration, you make sure you're supposed to have the patient has supposed to have the palpable lesion. So for example, if you are doing just blind aspiration, make sure the lesion is palpable. And if it's not palpable, then it's better you order the radiological imaging so that can help you, the guided aspiration. And most of the time when you do like aspiration, before you're doing aspiration, it's better to do the radiological, so that you know the nature of your lesion before you put your needle in. So that, for example, if you have a lesion which has both solid and cystic part, you're interested in both parts. So when you put your needle in, you're supposed to know this is the solid part and this is the cystic part. And all these have a meaning when you are coming to interpretation. And then the other thing which is very important in pre-analytical part is the specimen fixation. We all understand why are we fixing them. Because at the end of the day, you are viewing them under the microscope. And we want to see the cells as they're imitating as the way they are in the living body of a person. So that's why we are fixing them. So we are putting them in a special fixative so that they remain as close as possible to the state as they are in the living body. Also, we protect them from shrinkage, from autolysis, from bacterial fungi action. And also we fix them because we want the specimen to take the stains. So if the specimen has not been fixed well, and then you put the stains later on, you may find the other places they're not really stained, and then you may say that this person does not have malignancy, while it has, but the reason was just the specimen was not prepared well. Also, we have to know, like, different fixative may be needed for specialized studies. And also the special consideration should be made, especially the cold ischemic time. And that is the time from when the specimen is taken to the time when it is fixed. For example, in breast, when you do mastectomy, you may find somebody is doing the procedure and the specimen is left there until the end of the procedure, maybe after 1.5 hours or 2 hours. And then that's the time when the sample is taken to the fixative. I tell you, at the end of the day, this person will have all the receptors negative. So you may find our patients, they have receptors negative or low-level expression of HER2, but the reason was just for fixation. So are we doing it right? And even leave alone the cold ischemic time, we're supposed also to take the into consideration of how long does the specimen is kept into the fixation. Is it 48 hours or 72 hours? In some of the studies, they say after 72 hours, the HER2 expression now becomes low. So if you overfix, it's also the problem. If you underfix, it's also a problem. So you're supposed to do it right in every step. So the common fixation method we have in surgical specimen, we have neutral buffered formalin. You may find in most of the settings, they just use formalin per se. It's not neutral buffered, 10%. So that is also a problem. You might have like a bad report because just the specimen was not well prepared. And also for cytological specimen, we have 2 types. We have the Meiji staining, and that is for differential quick, and then the other one is 95% ethanol, and that is for Papa Nicolai. But also we are supposed to know that in a cytology specimen here, the main thing here is just to differentiate between the malignous and the benign lesion. In most of the cytology specimen, you might not have the definitive diagnosis. So in some of the studies, they just say the FNAs, they are just for guidance, especially for our surgeons. So the other thing is specimen identification. So all the specimens are supposed to be submitted in appropriate containers. So you might find somebody is having a very huge specimen, for example, a breast, and then it's squeezed in just this small container. You may find you use even a week for this specimen to be fixed. So it is supposed to be like the fixative should be 10 to 20 times the volume of the specimen. But is it done correctly? And also the specimen should be labeled, all the appropriate, the names, the date, and then the labels should be kept on the container itself and not the lid. And the specimen from different sites, they're supposed to be kept in different containers, and also even the samples themselves. So if you have a lymph node and you have a breast mastectomy specimen, they're supposed to be put in different containers. Don't just mix them. And then the other thing is filling in the pathology request form. So this is very important in pathology. because we don't talk to the patients, we talk to the request form, we also talk to the specimen itself. So all the details are supposed to be filled well. We have the patient's details. Thank God nowadays we have the system, the electronic system that you find the names and everything, but then the details of what do you want, the clinical status of that patient, because whatever we are doing in the lab is reflecting of what you are asking. We can't do anything that you didn't ask. Also, the clinical, the type of the test should be requested. Also, the sampling site is very, very important. If it's the left axilla, and those are the nodes you're supposed to say. If it's right, if you say. Because at the end of the day, you will say maybe this report does not specify. But I'll just say lymph node, and I won't be specific, and that will be bad. So that was the pre-analytical part. Now, what happens when the specimen reached into the lab? The first thing, the reception. So here, this is where we reject. And if the pre-analytical part is not done properly, when you reach into the lab, this specimen won't be accepted. And then the other thing is accessioning. So this is like baptizing. We give the specimen a new name. We give them a number. So that number is like a code, which is used like when the specimen is in the lab, all the movement are tracked by that number. So that is the number we normally find in different pathology reports. So that is the name of that patient. And from there, if it is surgical specimen, you go through the other process, from the grossing, tissue processing, embedding, sectioning, and staining, until when you go to the report. So what is happening in grossing? So here it's like you are doing consultation to your patient. Now here you are having your specimen, and you have your request form there. So you do the identification of that specimen. You're supposed to be measured, and there are protocols which are guiding of whatever you are doing in that grossing. There are standard protocols which are there, and every lab should choose one. For example, if you mention, for example, if you have a hysterectomy specimen, and in the report you didn't mention like this, you did this hysterectomy because of the benign, maybe somebody had fibroids, or you are thinking of endometrial CA, or you are thinking of cervix, or any other thing. You're supposed to mention that in your request form, because when you come here and to grossing, they are grossed differently. They are completely different. The way you gross, and when I say you gross, that means you are taking the sections and the representative part, because you cannot take all the hysterectomy specimen you cannot sample all, because the use of cassettes and the supplies in the lab is not proper. So that you're supposed to have a good representative samples from that specimen. So you're supposed to say, like this one, it was removed because of maybe fibroids, and that you think this is a benign. So you're going to gross it very completely. And when you come to endometrial, it's also grossed different, and cervix and so forth. So you're supposed to say that, and you might find if you don't have that information, and there's no contact of that doctor who did that, for me, I can do it anyhow, according to that history or short history. Maybe just say PV bleeding, abnormal PV bleeding, hysterectomy done, and the sample sent to the lab. Those are the kind of things we receive in the lab, so that I can do anything. And sometimes I can say maybe somebody is having this disease or this cancer, but it does not reflect of what your clinical presentation of your patient. And also in processing of cytology specimen, for smears and the aspirate, they are okay. But when you bring in the liquid sample, they're supposed to be centrifuged, because you must find the bigger part is just the fluid, and then the small part are cells. So they are supposed to be centrifuged, put into the slide, stained, and ready for reporting. So when you come to staining, there are routine stains and there are special stains. For example, in surgical specimen, the routine stain is a H&E. And when you come to cytology, the routine stain are Papa Nicolai and Meiji stains. They are all important, and they are supposed to be done in a correct way. So after staining, now we have the slides, and the slides are taken to the pathologist for reporting. So the other thing to think about in this analytical part, is it necessary? For example, the grossing, those are the point of discussion. Is it necessary for pathologists to do the grossing? Or can we train the histotechnologists to do that? In other parts, it's the pathologist who is doing that. But in other parts, especially in a low-income countries where don't have pathology services all over the country, I think it's high time for us to train the histotech to do the grossing, because the tissue processing is done by the machine, the histokinete. But then other things, the embedding, sectioning, and staining, it can be done by histotech. But only the grossing part is left for pathology. So how many pathologists do we have? So if we train the histotech to do the proper grossing, they can do that. Even in remote areas, can be done everything. And then the slides can be, can use the slide scanner and send the pictures to pathologists. And pathologists sitting anywhere can report them. So these are like the point of discussion. So when you come to post-analytical part, the phase, here is where you talk of reporting of the slides, the storage of the leftovers, and the records. So the reviewing of slides. So the accuracy of pathology report is fundamental, as I've said, to treatment and decision and good outcomes in cancer management as a concern. So reports should follow established guidelines and include prognostic and predictive information. For example, if you are saying non-keratinized squamous cell carcinoma, then you're supposed to say maybe the grade, because that will tell you the prognosis of that patient. If you have the grade 3, that means that tumor is growing very fast. And even we can see even the prognosis maybe of that patient is going to be very bad also. So those are the things that are supposed to be in report. But to cater all that, there are system of structured reports that I've done, and that is synoptic report. But are they used? Like you find, I think now you can even think of those, they report the oncologists, the reports you are receiving. Let's say you are receiving from Ocean Road, you're receiving from Mbili. They are not equal. You may find they have maybe the important things, but the way it is structured is completely different. So it's high time to have that good network, that we have a good structured report templates that can be used all over the country and have like the same way of reporting. So what is this synoptic reporting, and why are we supposed to use it? First of all, it helps the clinician to produce complete and consistent and valuable medical reports. And it also helps in TAT, the turnaround over time. And also, it helps to ensure consistency of the reporting system. And this is very busy slide, but at least it shows the by College of American Pathologists, and this is just the reporting of uterine cervix excisional biopsy. They have templates for most of the cancers. So this one was just for cervix, and you find it tells you the specimen type. So which one do we use? You use the lip biopsy, you use the cord biopsy, or any, so you just tick there. And then you have the tumor site. It tells you where the tumor site and the tumor size, the histological type. They have mentioned all of them. The histological grade, the stroma inversion. Those all of the things that they are found there. So it's very easy to like fill in and make sure that you don't forget any part, which is very important in their reporting. So the other part is about the intentional disposal of tissues. So like you may find in other pathology services, that we have different protocols, but it is recommended that you maintain at least the blocks that are made in the slide, at least a minimum of 10 years. And remnant of tissues can be discarded after 30 days. And also, there should be a written policies that involve retention of time, location, and a system of storage. The other thing is archiving of patient data and report. So the patient data and report should be retained permanently. And also the other thing on reporting, it's high time, I think, to think about, so who is supposed to report what? So you might find, because of the scarcity and a few number of trained pathologists, you might find one pathologist is reporting like all type of malignancy, which is not possible, and the efficiency should be very low, because I cannot report the GIT, I cannot report the pelvic, the CNS, like everything, even the quality will be low. So I think it's high time we have like good specialization of the pathologist. So if somebody is doing breast, should report breast. If somebody is doing nephro, should report all the things concerning the nephro, the GIT, and so forth. And also, like how many pathologists should report for a report to be disposed, how many pathologists are supposed to be involved? A minimum of 2. There should be one and the other one for approval. So I think that will be in the protocol and things to think about. So in conclusion, these are the true cases that are happening in the ground. So you have a 59 years, so I won't need the answers, but it's something to think about as pathology is concerned. So you have a 59 years old female who came in a screening department and complaining of postmenopausal PV bleeding. So on a speculum examination, there's no obvious lesion. VIN, VILE, all were done and they're negative. So what should you do? Should you do a PAP? Because such a history, you find people are doing PAP, punch biopsy, lip biopsy. So what is supposed to be done? Should we do all? Like somebody's doing PAP and then punch biopsy? So those are the things to think about. And then the other thing, you may find like a patient comes in with the right breast lump. Is it okay to do like a FINAC followed by a biopsy? Or can you go straight? If you think this clinical is really, it tells you like this is malignancy. Remember, in the beginning I said, before like deciding type of a procedure or type of specimen to bring into the lab, you're supposed to know the natural history of a disease and the clinical presentation of a disease. So such a presentation, are you going to do like straight a core biopsy so that you get a good specimen which you can tell you the histology, and then at the same time you could also have the receptors and HER2 expression, or you're supposed to do the FINAC first and then you go to core or any surgical excision. And then the other thing, you find that woman comes in the left breast fungating mass. Such a thing, you can find somebody is bringing you to the lab and do the FINAC. What for? Such a thing. Okay? So these are the things that we do every day. And then at some of the scenarios, you find you have a referral case, and then your oncologist is just sitting in the clinic, and then you have a 63-year-old male with a progressive history of abdominal pain, which is associated with distension, has a weight loss, and yellowish discoloration of the eyes and mucous membrane. You also have a biopsy which says colon adenoma with atypia. You decide to do your wake-up, your FBP, your chest X-ray, the abdominal pelvic ultrasound and CT. The ultrasound and CT, they tell you like this person is having liver mets and lung mets. They suggest that. The next step, it's a call to the pathology lab. In such a case, pathologist, what are we supposed to do? Do we send a patient to you so that you do a slide review? Should we give you the blocks and do slide review? Or just do slide review and immunohistochemistry? Or should we send it back to a surgeon and rebiopsy? If you are there, your oncologist, what would you do? And this was a true case which happened like a month ago. And then the other thing, we have a breast patient, post-chemo radiation with contralateral breast lump and axillary node. So what is supposed to be done? Is it FINAC? So what are the things that we're supposed to consider before ordering? I think those are the things that you're supposed to think about when you're putting a recommendation for ThinkWise in pathology. And the other thing, like a CAX patient, this cancer of cervix patient, post-treatment with supraclavicular node. These are the things we receive every day, like the fine needles. Okay, the fine needle will tell like this one is carcinoma. But then is that helping you guys? So this is the time and these are the things you're supposed to think about. So after doing all what is supposed to be done in a correct way, then we can think about having molecular pathology. Then we can think about having genetics, molecular pathology, genetics, immunopathology, and even forensic pathology. But if we don't have this normal histopathology, this normal cytopathology, which we call them at least basics, then we cannot even think of having molecular pathology in our services. So let us choose wise, and asanteni.